Good evening, everybody. Thank you so much for joining us for tonight's webinar. We're very excited to have Dr. Wolfgang Liedtke here, along with the FPA Medical Advisory Board Chair, Dr. Jeffrey Brown. We'll get started in just a minute, but I just want to make a few quick announcements. To view our past webinars, please remember you can go to our YouTube channel and our website. And we have several upcoming events, including 2 webinars. We have one on upper cervical chiropractic on Wednesday, June 30th at 7 p.m. with Dr. Larry Arbeitman. And on Wednesday, July 21st, we have a webinar with Dr. Lisa Scott Morrow on anxiety and facial pain. We also have a Facebook Live event coming up on the topic of pregnancy, motherhood, and facial pain. And that's going to be on Wednesday, June 16th at 8 p.m., all Eastern time. If you have any questions about any of our upcoming events or how to access them, please feel free to email us or call the FPA office. Finally, please remember that your gifts to FPA make a real impact on our ability to continue to provide these free educational and support programs. Please consider making a gift to the Facial Pain Association. You can visit our website or give us a call for more information. And with that, I'm going to turn it over to you, Dr. Brown.
Good evening, all of you. I'm Dr. Jeffrey Brown, and I chair the Medical Advisory Board of the Facial Pain Association, which I am fortunate to have been a member of for the past quarter century. It is our duty to assist the board of directors by advising them about the medical issues which you all face. And tonight, I'm really quite excited to introduce Dr. Wolfgang Liedtke. He has a distinguished background, and I thought I'd tell you about him before we start. Dr. Liedtke received his medical degree from the university in the beautiful city of Cologne in Germany, went on to get a Ph.D. in medical virology from the Ruhr University, trained in neurology and psychiatry before he came to this country, first as a neuropathology fellow at Albert Einstein College of Medicine, and from there he spent 6 years in research at the Rockefeller University here in New York City. For the past 17 years, he's been a professor of neurology, anesthesiology, and neurobiology at Duke University, until he left just this year to chair neurology and global development for the Scientific Council of a company called Regeneron Pharmaceuticals, which, as I understand it, focuses on the development of immunological solutions to the treatment of disease. I hope I got that right. I am going to turn Dr. Liedtke loose to you, but you may hear me throw in some questions that I have as I listen carefully, as I hope you all do, to his discussion of what I have titled the medical treatment of neuropathic trigeminal pain, but what he has subtitled this talk on is a review of his 17 years involved in pain management for neuropathic facial pain and his concept of a joint clinical arrangement for its treatment. Dr. Liedtke.
Thank you so much, Dr. Thank you, Jeffrey. Thank you so much, Dr. Brown and Allison, for hosting this, and it's a great honor for me to be presenting and sharing with you this evening, where the evening sun of Durham is shining into my home office and giving me a bit of southwestern illumination here. So I'm happy to be here and to talk to you about trigeminal pain, a subject that an area of intense interest of mine that I have pursued since becoming a more dedicated research scientist at the Rockefeller University and then at Duke, setting up my own lab, my clinics. And the interest has never left me and also has guided me in my decision to leave the academic world as a scientist physician with laboratory going well and being a popular doctor and seeing that I was able to help some and to accompany as people suffer with this horrible disease, guiding my decision to get into the corporate world, where I felt that with what I know and can bring to the table will perhaps become reality one day soon, and rather sooner than later, whereas academic research has a longer perspective. And I think I can give you a little bit of that when I guide you through my talk, which I have tried to bring together my clinical experience with my patients, and also working with other doctors and learning from other doctors like Dr. Brown and colleagues in other disciplines who I have learned a lot from, and just keep the doors open for getting inspired by others. And my science background, where I learned in the lab, and I was part of a multi investigator team, and that has just come together so far. And I'd like to share with you and try to communicate at a level that we can all that we stay at that level that we can all share together. All right. So I'll show a presentation, a modification of a presentation that I have given at American Association for Orofacial Pain, and it went very well and was well received. So I tried to adapt this presentation for all of us this evening. So here we go, and here is my title. And can you see that, Jeff? Can you see mine?
Yes.
Okay, great. And I go to the slideshow, as we discussed. All right, so here we are. That is, it used to be that I'm put Duke and talk about Duke. Well, now I'm at Regeneron. It's still considered a biotechnology company, but it's quite successful and innovative, and has a motto of science to medicine, and I completely subscribe to that. Well, I was at Duke University and was inspired by people like Robert Lefkowitz, and also Robert Califf, who then went on to become FDA commissioner. And so it's not only about basketball there or sports, but still, I like to play to win. So, and I see this green ribbon here, show this green ribbon, that it means a lot to me. It does. All right, I'm at Duke. I was at Duke 17 years. I also joined New York University in dental pain research. And that is also of importance to me. A group of investigators whom I like a lot, Dr. Bunnett, Dr. Schmidt at NYU, so giving me an academic leg in the city I call home in the United States. I am involved in a company called Achilles that makes topical treatments against migraine and give them advice. And I founded a company, Trip Blue, that makes small molecules against nerve pain of cancer chemotherapy, also externally applied like ointment or gel. And now I'm chair of neurology at Regeneron. So, and then next slide, 1 second. How do we get there? Oh, okay. All right. So
We're drawing a blank here.
Yeah.
We're not seeing their slide.
Which one?
No slides. I got a white screen.
You've got a white screen. Okay. Let me see what I can do.
There you go.
To see.
We have a pained face.
Yeah. Let me minimize that. Okay, so now we'll maximize that. Yeah, you see that?
Yep.
Okay. Yeah, I'm just saying that I am a creature from two worlds. One is laboratory-based science with intent to translate, and the other one is I am a clinician who is trying to help people. So clinically and laboratory-based investigator. And as a clinician, I'd say I have become a very apt curator and treatment go-to person for comorbidities, such as dental pain, dental comorbidities, and have also treated patients with temporomandibular joint pain that became a trigeminal pain disorder. So that has influenced me over the years. Here are more comorbidities, like a young patient of mine who suffered a orbital floor destruction through a tumor that was essentially
white screen again. You can't see.
Can't see.
That's okay. Just keep talking.
Well, I would like to show still widescreen. Oh wait, I can see what you can see. Okay, we need to fix this. It should be back, right?
Yep.
Yep. Okay. So this shows some of the comorbidities I have treated, like the orbital floor was destroyed through a tumor. Tumor was essentially cured, but the patient suffered from nerve pain through the tumor, and I have tried to help this patient with her nerve pain through the destruction of the orbit, and we are trying to essentially rebuild the orbit. We have helped rebuild a mandible that was destroyed through a failed dental implant process, and we have helped a patient who had a tumor of the trigeminal nerve root with the help of capable neurosurgeons, of course. Wait a second, that should get us in next. Yeah, okay. So important slide now. How do we do this? And that is my proposal. We need to build teams, and I try to illustrate it on the right-hand side. Work together, flat hierarchy, no courts and emperors, but flat hierarchy, working together with therapists, with social workers, with nurses, with people who come together to try to help to fix this disease, because pain knows no boundaries. And we cannot say, oh, you are a surgeon, you're an anesthesiologist, you are an XYZ doctor, and therefore you are responsible for pain. That needs to be left at the door, and then we need to focus on pain. And I listed a number of disciplines in medicine that come together to do this. But I also say, importantly, we need, for example, we need pharmacists who can help us formulate medication that you don't get out of the shelf. We need psychiatrists who are particularly open to the impact of chronic pain and influencing the patients through the relentless onslaught of the pain, of the chronic stress. Specialists for older patients who suffer from pain, because in older patients things are different, and they, same rules do not apply. ENT doctors, ophthalmology doctors, eye doctors who are open to pain, who do not say, oh, you don't have this, you don't have that, so bye-bye, see another specialist. It needs to be this openness. Oncologists, I always had good experience. They are oncologists, to my experience, pretty open-minded to try to help with pain. And last but not least, dot point is we need people open at the administrative level to try to help us, our patients, especially in the first place, in the entire team, that we have administrators helpful, reducing paperwork, reducing red tape. And I list also, we need pain lawyers. We need people with a legal background.
That's scary. Tell me about a pain lawyer.
Yeah, pain lawyer is somebody who has a legal background, who can help with paperwork, with regulations, who can help doctors and teams to overcome fights and altercations with insurance carriers and people who just set up obstacles and hoops. And that needs to be fought. And it's a major distraction from our mission to try to help and to try to work together to diminish patients' pain. And we need people
is this a virtual network that you put together, or is this an actual group that sits down and talks about patients?
Well, if we come out of the pandemic, I'd say my ideal pain clinics has a room and an office where that pain lawyer has her or his own office and is there. And if you need to, you step in and you can have a 2-minute consult that is way more effective than 50 emails, and you get things solved on the spot. And you have that person is also has that open-mindedness and participates in the morning meetings and participates in the agenda meetings, so that they know this is what we do. I come to it from a legal standpoint, but I'm not ignorant about medicine, and I'm open to it. And my job is to help the doctors and nurses and the patient to overcome these obstacles and hoops that are being held up. Where if you are normal and healthy, that can be exhausting enough and you complain. But if if a patient has that form of pain and then is asked to do that, it's just cruel. And we need to answer that, and then to say, okay, I'm the doctor, I'll try to take care of that. Yeah, I tried that over the years and I got good at it. But that's where I say, well, if I had a pain lawyer, I would fight back, and I would give that colleague some instructions what to do.
I'm interrupting, but that is the most unique concept, because sometimes my patients, I tell them they have to call their congressperson's office to get help.
Exactly. Where that's sort of okay. That is something that leads us to. I also think we need public relations and people who advocate, like Ellison. We do need those associations and those groups who speak and who communicate on behalf of the patient who are muted because they can't speak because they hurt. And so we need those spokespersons, that people who powerfully articulate and also who help, getting rid of many nonsense rules and nonsense provisions that are in front of us. And that is okay, that's the way it is, that's the way life is. It needs to change, and that it is overly exhausting if you are the doctor, if you are the caregiver. That's something where I say we need specialization here, and
I'm sorry to interrupt. That's the most important concept I could think of. That's a great idea. It's a patient advocate position based in the legal morass, which is our medical system. I'll let you go on. I'm sorry. I'm excited about that.
Exactly. And then you see the last photograph there. You see that rowing together. We need to row together, and you have synchrony in your blades, and you're not allowed to have asynchrony or asymmetric power on the right and on the left, and then your team, and then you move forward and you can win. And that's what I believe we should be doing. She who suffers should never land between the chairs. That is sort of the bottom line. And also then from our perspective, doctors, nobody owns trigeminal pain. That's something, it goes into so many disciplines. We have to forget about this, like I belong to this, I belong to that, I'm the emperor, you're the receiving my orders. Forget about it. We need to do that together. Yeah, that's sort of 17 years distilled into this. Okay, next slide.
You're in charge.
Yeah, if
Make
I
it
could
happen.
do it, yeah. There we are. So just some examples that highlight the trigeminal system in the brain is a unique system. It's not just a nerve, it's not just a ganglion, it's a system of neural structure that are superbly endowed with sensitivity to detect danger, and has made us better animals, better survivors, better success at reproduction. That's how this system has come about. But when it is not functioning right and is overly sensitive, it can lead to a unique type of disease that is so debilitating that it stands out amidst other forms of pain. And so we are looking here at a particular anatomic unique anatomy of the system, where the so-called trigeminal nerve root connecting the brainstem, and is this cursor visible?
Yes.
Okay, so the brainstem, that is a super important part of the brain, where very basic function like respiration is happening, cranial nerve nuclei are located, connection between the brain and the spinal cord, the brainstem, and has these large cables here. That's a trigeminal nerve root, so-called cisternoid trigeminal nerve root, well visible here, and that connects to the trigeminal ganglion. Trigeminal ganglion is where the nerve cells live, and then the trigeminal ganglion gives rise to the three branches: first branch, second branch, third branch. They are the ophthalmic nerve, maxillary nerve, mandibular nerve, the main branches of the trigeminal nerve in the periphery. And then this cable connects to the inside of the brainstem, which has an organization how the sensory impulses are conducted, and that is separate for non-pain and for pain. And I'll show you some example of research that we have done, which is there we are. And we can skip that one. We have understood this structure because this is a target for successful operations and successful procedures in case trigeminal nerve pain comes up and is a subject, which is a microvascular operation that you do, that Dr. Brown does, a very successful measure to alleviate trigeminal neuralgia pain. And then we know that this cable has an organization where the first branch is up, the middle branch is in the middle, and the third branch, the mandibular nerve, is at the bottom. So that we have this called somatotopia. And here is a research that I wanted to mention and bring in, which is together with my friend Fan Wang, who's shown here. And Fan is, let's say, is a prime time neurobiologist of the 21st century, and a super smart, super capable colleague whom I met at Duke, and she now moved from Duke University to MIT, where she has her own group and lab in the McGovern Institute for Brain Research, but she's continuing to work on trigeminal sensory system and pain. And here we discover a way how the trigeminal sensory system functions that was unknown before we published this. And that is, the key point here is that trigeminal system has a direct connection to the emotional brain. And that is, it does not take a detour. The detour is this: if information, painful information enters, goes down and goes back up through multiple synaptic relay. Fan and our group, we discovered that trigeminal pain goes in and without delay, without synaptic relapse, goes to a central hub that directly connects with the emotional processing centers in the brain. So, and that, importantly, trigeminal pain has that, other pain does not. And so with that, it's
So
like,
where is that? You're going to the corpus callosum? Where are you going to with this emotional processing? Where is that arrow pointing? What are you calling the emotional?
For example, pointing to amygdala and frontal cortex. So so-called limbic system, limbic brain, the emotional brain with amygdala and prefrontal cortex. That's I think those two are shown here in red, and it goes from the so-called lateral parabrachial nucleus to those amygdala and prefrontal cortex. That is summarized as emotional processing centers.
So to emphasize, you're saying that the trigeminal system uniquely, directly connects to the suffering parts of our brain?
Yes, exactly. There's also, from here, it also goes directly to the hypothalamus, sleep, wake, appetite, thirst for water type of centers in female, regulation of the menstrual cycle. That's this direct connection that it carries, and is previously unknown, discovered in Fan Wang's lab with my collaboration. So I'm very proud of that discovery that we made together at Duke University. And it explains the devastating nature that trigeminal nerve pain can have on people, on patients suffering from it, and how it affects them emotionally. And that is other pain that is mediated through other nerves in the body. By our research, we did not find evidence that other pain has this direct connection. So
it is uniquely different from back pain and leg pain and arm pain and all those other pains.
Yes. Yeah. We say future research, we should investigate whether, for example, abdominal pain or pancreas pain has perhaps a connection like this, which we just did this, what you mentioned, arm pain, leg pain, sciatic nerve pain, bone pain, that we checked. But there are some special forms of pain where future pain research will have to show this. But we are the first to show that trigeminal pain has this connection, other pain does not. That's the status so far, and it does explain this devastating impact on the emotional impact of this form of pain. So these are methods that we used, state-of-the-art method to deconstruct this and to discover this, and it is really powerful. So here's again a summary. The red nerve cells are pain nerve cells, and they connect directly. And then here is an intervention that is also used in pain management, in neurosurgical pain management. It's called DRESS, dorsal root entry zone coagulation or nerve ablation. And for the trigeminal system, it can be done here. And that is, it is when the patient is properly pre-selected, DRESS procedures can be quite helpful and good. But our point here is that we are in need of leveraging this new knowledge. And if we do a DRESS procedure down here, we will never capture this connection. We will never be able to impair these impulses because it's just anatomically several inches apart. And then perhaps, as I say, 21st century version of the DRESS procedure is needed that will target these unique nerve fibers from the pain neurons in the trigeminal ganglion that directly.
So you're saying this DRESS procedure might affect your sensation, but it doesn't affect how the patient reacts to that sensation, the suffering that comes.
The DRESS procedure will affect the traditional loop that goes from the TG and down, which it's not that this is the only one. So there are other pain pathways that enter the brainstem and they go down, and then they relay down here. And the DRESS, the classic DRESS, will affect those, but it will leave these direct to the emotional brain connections. It will not touch them because it's just anatomically different, totally different. And I'm arguing that if this can be has been found to be a helpful procedure for at least for some patients, how about we consider thinking about targeting this one? So that's where our research also had an angle that it's not just academic research and an increase in knowledge, which is satisfying in itself. It also has a practical relevance. So
that's scary territory up there.
So yes, it is, and certainly what you can do down here, you cannot readily do up there. That's it is understood, but knowing that you want to be up here can perhaps help us develop these new methods that we might need up here as compared with down there. And needless to say that Fan Wang at MIT, I'm at Regeneron, but we have an understanding that we will continue our years of work together. So, all right, I think I don't need to speak that much about that. The trigeminal nerve root is bothered by a nearby artery, is exposed to mechanical trauma, and then that is being repaired by putting something in between. And that the success of that procedure, going back to Dr. Janetta, that has told us a lot about what is important and critical in the trigeminal system, namely that connection between the trigeminal ganglion and the brainstem. That's an important anatomic structure to consider if we want to be successful in treating this form of pain. But that means we have to get into the patient's brain, into the patient's skull, and go several inches deep, make an incision and drill through the skull behind the ear. Subject the patient to several hours long operation, microvascular decompression, and that is, of course, it is an invasive maneuver. It is drilling a hole into a patient's brain and operating for several hours, several inches deep, around the vital center that directs respiration, blood pressure, and other vital functions. So that is not done willy-nilly, and therefore it is a possibility. And it has taught us also some good knowledge about the disease that we haven't had before we were doing these operations more frequently. But there is also a certain threshold that exists before one proceeds to say, oh, we need an MVD here. Okay, the pathophysiology, we can just skip that here. But here's a really important question where we have trigeminal neuralgia, which is flash-like, this form of pain, electrifying, flash-like pain, stabbing pain for seconds. The French say tic douloureux, which means the electrifying tic that is so overwhelming, versus nagging pain that doesn't go away and is there and is there and is there and is wearing the patient down emotionally through its persistent presence. So that is, we have neuralgia pain is G50.0, and the neuropathic pain, that's G50.1. There are patients, not so few patients, who have both. So there is presence of both forms of pain. But the question arises, why is it that there is neuralgic pain and there is neuropathic pain, and then we can see this problem. We can see this problem in both, sometimes in patient, but in the neuralgic pain, this measure to relieve the pressure from the nerve is quite successful, whereas in the neuropathic pain, the success rate for that operation is not that high. And so it indicates that these are forms of pain that are not, that also share something, of course, which is they can devastate the patient, they can emotionally wear them down. It's the same nerve, it's the same structure, but they also have a critical difference. First, how it feels, and then secondly, how they respond to this form of treatment. So why is that so? And there are some ideas and some characterization, but at a deep level of why that is so, that is still an open question.
You got me excited for a second. I thought you were going to answer the question. All right.
Well, I would love to, and I would love to in a way that follows a pattern of what Tran and I have done. So, bring cutting edge, cool science to the table to do that, and then also in a way that we can use new forms of treatment that will help us, and we will notice that, okay, this form of treatment that we have rationally devised helps this type of patient's pain, and then others it might not. And then if we can explain that would
let me put you into the real world. So you come down with G50.0, stabbing electric pain. Can you get down to the basics of how you start the treatment process once you've made the diagnosis?
Absolutely. The practical, going back to the front lines, what do you do? Okay, so here we are. Treatment options, which I list here on the left-hand side, anti-neuralgics. Those are medicines that will attenuate and that will make milder these shock-like, electrifying and stabbing forms of pain. And listed here in the up front is carbamazepine, oxcarbazepine. And as we exchanged by email, I would always use that first time also to establish whether a patient has a response. These medicines perhaps likely work against trigeminal neuralgia pain because they block so-called sodium channels. So they are sodium channel blockers that makes them effective. And there are other sodium channel blockers that we can also use. And I have listed that here. Zonegran is one of them. And then in bold, because I like it so much, is lacosamide slash Vimpat. And that's my use as a result of my years of practice. I say I have helped many patients with Vimpat prescriptions that were otherwise not doing well, even though they had carbamazepine, oxcarbazepine. And so to me, Vimpat is just over my thumb, even though I have not carefully analyzed the data from the files. Vimpat is to me a superior medication over carbamazepine, oxcarbazepine. But I think if
let me ask you, what's not on your list? There's this drug called Lyrica, which has become very popular.
Lyrica is right here. Lyrica is right here.
Oh, pregabalin.
Yeah, there we are. Yeah. So that I also list that. Those are the so-called gabapentinoids, gabapentinoids, and the second one of those is Lyrica, and they also have a place in fighting neuralgic pain. But to my estimate, or with my experience, carbamazepine, oxcarbazepine, Vimpat are just have more punch and more power. With the gabapentinoids, one needs to slowly increase and increase and increase, and then it can also lead to a satisfactory outcome. Perhaps if you compare gabapentin and carbamazepine as very basic medicines, that gabapentin is overall more safe and less discomforting, and has a chance that you can start dosing it at lower dose and then slowly increase and increase and increase. And at one point, and there could be several grams, at that point the patient will say, okay, I'm fine. I'm much better now, or I'm good, and side effects are nothing for real, nothing bad. But the trick here is
Well,
that
when you say grams, you're talking thousands of milligrams.
yeah, I'm
in
saying, for
Neurontin.
example, not untypical is to have a patient on 800 milligrams 3 times a day. That is a middle of the road doses of gabapentin for trigeminal nerve pain, and that can be a very, very good solution. But the
And
one thing is,
when you say slowly, what's slow mean to you? A week, a month, a year? How long does it take?
Start these patients on 100 milligram or between 100 and 300 milligram 2 to 3 times a day, and then have a weekly increase of sort of doubling the dose every week, every 10 days. And then that would lead to finally reaching a dose of, let's say, 800 milligrams 3 times a day, which would take 8 weeks, 10, 12 weeks to get there. And that can be in a situation.
Or Neurontin. That's not Tegretol. You're not going to take that much Tegretol, I assume.
Oh, no. So the Tegretol, you would be starting with a trileptal 150 milligram twice a day, and then escalate to 300 milligram twice a day, and then can go to 300 milligram 3 times a day. And at that point, a response of the trigeminal nerve pain to that drug should be there. Otherwise, it would count as no, that's not it. That drug is not helping. And the strictly neuralgic pain, the oxcarbazepine, carbamazepine not helping, I would say that is perhaps 10 to 20% of patients that have this form of pain, very classic textbook appearance, and maybe a 10th or a 5th of them do not respond to carbamazepine, oxcarbazepine. Very interesting, because it means that this standard type of sodium channel blocker, you give it to them and you reach a good dose and the pain is still there. And that means you could perhaps differentiate the groups of patients that have form of pain responsive to carbamazepine. That's the majority, vast majority. A small portion have pain that is exactly the same presentation but has no response to this drug. Then the patient no response to carbamazepine oftentimes it's not difficult to help them with gabapentin or Lyrica, which are in the first place they are interchangeable. They can be used in both cases. I do realize there are some patients who respond better to one of them, and that has no good basis why that should be so if we think about scientifically.
Do you tend to add a drug or take one off the first drug and start the second drug when you treat people?
Right. If I have a non-response to carbamazepine or trileptal, I would say, okay, forget it, drop it, and we'll put you on gabapentin and try to increase to this dosing in.
But you're not a multi-drug person. You're one at a time person.
In the beginning, I would go with one. Overall, most patients who came to see me were treated with a multi-drug regimen, and that is so because the pain they suffered from was so bad that they were not helped with just one drug. And I do believe that rather than max out the drug and bring it to the max and above it, and then say, okay, we just deal with one, I have made better experience with rather using 2 or 3, and then each of them at low dose. Because my rationale has been that each drug can fight pain, and what is listed here has a record in working in trigeminal nerve pain. Each of them can fight pain. They do that in a different way with different mechanism, and then we can get the anti-pain effect that comes together and synergizes, and then the side effect will be it will be left out, or it will.
So are there two drugs that you routinely say work by different mechanisms that you would use together?
Yeah, sure. I think the combination of gabapentin and duloxetine or the Neurontin and Cymbalta, that's a winning combination, and that is where, for example, I'd say if we have a trigeminal nerve pain that is caused by shingles, so shingles come, hurts very badly, shingles go away, but then what is left behind is a so-called post-herpetic nerve pain, and that can happen in the trigeminal territory. It's not a good thing to happen, but I have seen a number of patients who were helped nicely by combining gabapentin with Cymbalta, duloxetine, and for sure no significant response with either medicine alone. And
So let me just help people. Duloxetine is the generic word for Cymbalta.
correct. Yes.
Okay.
Which is it in itself also. It's a good medicine. I like Cymbalta. It's a good pain
And how
medicine.
does Cymbalta work compared to the others? Does that work for a different mechanism?
So carbamazepine sodium channel, gabapentinoids is so-called calcium channels, exon calcium channels. Lamotrigine is doing several things, also anti-sodium channel, and also other things that make nerve cells more stable. Duloxetine Cymbalta is a so-called SSRI, SNRI, and that abbreviation means selective serotonin inhibitor of reuptake. And SN is selective norepinephrine reuptake. So those are messenger chemicals in the brain, serotonin and norepinephrine. And the duloxetine Cymbalta makes these messenger molecules more available. It enhances their function. And so duloxetine is like Prozac for serotonin, but also is not only like a more powerful Prozac or Prozac 2.0. Duloxetine is different in that it has a Prozac function and has a function against to boost the effect of norepinephrine, and that means it influences two major neurochemicals in the brain, and that's the magic about Cymbalta, where Prozac is not a bad mood medicine and has helped many people with depression. But Prozac in itself is not a very good pain medicine, whereas duloxetine is a much better pain medicine. By the way, it also might help with a mood disorder. But so there you have that difference. So duloxetine.
Let me summarize. You would often use carbamazepine or Tegretol with gabapentin, and you would also use Cymbalta with Neurontin, gabapentin.
Yes. Those can be
Now,
winning.
I have a question. I'm sorry to bug you. A lot of my
No.
patients think that they're doing something special when they take the extended release versions of these drugs. Do you notice any difference? Do you use extended release versions of any of these?
Extended release can be good. That can make a difference and make a patient who has some response, and we know, okay, the drug is working, but there are fluctuations, and part of the day they are good and other part of the day they fall into a hole. And then use of the extended release formulations, that's a solution, and that makes life much more manageable and more normal for patients, and that can be critical. That we have seen that, and it's a matter of I think first trying out the regular versions and establishing that there is a response, and then seeing how it can be managed. And there are patients, and if you give them, let's say, 4 tablets of Tegretol, regular Tegretol, 4 tablets during the daytime, and that will work and it will be good. But then it could be difficult with their daily activities, and so they better have 2 extended release, one in the morning and one in the afternoon of that medicine, rather than 4 times a day. And the result is not so different, because with the 4 times a day, that is sort of like a extended release formulation, whereas the extended release are a little bit more convenient, just two takes. So extended release can be quite good, and sometimes problematic with the insurances because they are more expensive. So
yeah, I have patients that have tried ketamine by infusion. You want to talk about ketamine nasal spray and how you use that?
So we have these medicines are prescription and not difficult to get, and generic versions exist, etc., etc. Lacosamide Vimpat has a patient assistance program where they typically jump in if the insurance doesn't cover it, and typically UCB Pharma gives a medicine out for free. You have to fill out the form, and the doctor has to sign it. Then we come to ketamine nasal spray and low-dose naltrexone. So both I bolded them because they are important. So let's talk first about ketamine nasal spray. And I borrowed the approach here from successful use of ketamine nasal spray at a dose of 100 milligram per milliliter. And if the compounding pharmacy can make it higher, was successfully used to treat the pain of fibromyalgia. And that is a super nasty pain that especially women suffer from. and that has a quality. It's there all the time, and it's wearing the women who suffer from that down. Ketamine nasal spray has been found to be helpful with that, and then I said, okay, if it helps with that, why not try it in trigeminal nerve pain? And I also made very positive experience with it. And since it's a nasal spray, it has an added advantage. It goes to the trigeminal territory, namely to the second branch when the patient sprays it. It also goes to the blood, through the nasal mucosa, like nasal spray insulin or other nasal spray medicines, nasal spray migraine medicines, for example. And so ketamine nasal spray has that advantage. And I also made very good experience with ketamine nasal spray for attacks of pain. When the pain attacks are coming, and especially the patient has a feeling, has a premonition they are coming, and ketamine nasal spray can be really, really good and change the life of a patient.
So they carry a little spray thing in their pocketbook, or
they have it with them, and they have it on their night table, and they have it in their bag, and they have it with them. It's enormously reassuring to have this as needed medication with an ultra rapid onset in a patient's pocket, because the patients know with that they don't have to render to an urgent care or emergency care if things don't go well, and they can start helping themselves. And that ketamine nasal spray is, to me, is a big winner and is a big enrichment of the treatment landscape in trigeminal nerve pain, both for attack-like pain and constant.
Can that be prescribed, you said, or it has to be made up by a pharmacy special?
Yeah, so there is now Spravato, ketamine, that is FDA approved for treatment-resistant depression. Spravato is really guarded and very exclusively used only in that indication. So if it's used and try to use it in trigeminal nerve pain, Spravato will not get approved, or I haven't heard about that successfully being prescribed, and it's about $1,000 out of pocket. So then the alternative is ketamine nasal out of the compounding pharmacy, and it has to be written as a compounding script for 100 milligram per milliliter. And then one has to indicate the maximum number of puffs that are allowed. And I typically start with allowing a maximum number of 24 puffs a day. That's 2,400. That is 240 milligram. That is compounded and is relatively, if it's not covered by the insurance, patient insurance, is relatively inexpensive. So has to be compounded.
What do you think about ketamine infusions intravenously?
Yeah, ketamine infusions, I believe, should be offered by infusion centers and medical centers as a sort of a last resort alternative, because there will be patients who will respond to it well, and I think we should not relegate ourselves to not offering it. There will also be a number of patients for whom it will not work, and then that's an experience, an unfortunate experience that we have to record and say, okay, we tried it, it does not work. And that, of course, with the infusion, you will try to fight a form of pain that has gone out of control, and you need to take some more drastic action to contain it. And I believe that we should have the option of using intravenous ketamine for that purpose. But there is many.
What would you do with a patient who says it's out of control? I can't live, I can't eat, I can't drink. Do you have an emergency cocktail that you give people to stop the pain? And it's
yes. So there should also be emergency room and urgent care options for trigeminal pain that is out of control. And if the patient does not have ketamine nasal spray, chewable carbamazepine, liquid oxcarbazepine, and in that place we do need to mention the orally dissolving clonopin. Those are easy to supply medicines that I have prescribed liberally and in widespread use to my patients, so that they have that at home themselves. But there are many patients who don't have that, so I would urge urgent care and emergency care to have these as choices. Beyond that, if those have failed, so if a patient of mine had all the good things in their pocket, they use it, now it's ringing, the pain is 10 plus out of 10, what to do? So in that case, one wants to go intravenous and use intravenous medications, and there are combinations of medication that can be quite beneficial, such as intravenous should contain compazine or promethazine as an intravenous medication. We borrow that from intravenous treatment, emergency treatment of migraine. In that controlled study, that migraine that responds to nothing is responsive to these medications, and migraine responsive to nothing is also a pretty nasty state. So compazine in the emergency room with pain out of control for sure will need to control the blood pressure, because most patients have out of control hypertension in response to this horrible pain and the stress that comes with it in the ER situation. So bring down the blood pressure with ER measures, and that could be try something oral or try something intravenous, bring down the blood pressure to below 140. And then compazine or promethazine intravenous, I would intravenous also add diazepam to sedate, and then specifically against the pain in the emergency room can do phenytoin as an intravenous sodium channel blocking drug, old drug. Also can do in the emergency room lacosamide as an anti-seizure medication, has an intravenous formulation. So ER application of intravenous lacosamide, very specific against trigeminal nerve pain. However, unfortunately, not many ERs have that. Then what ER can do for sure, unfortunately, many doctors reluctant to do so, is lidocaine IV. Intravenous lidocaine intravenous acts as a sodium channel blocker and can be very effective at suppressing trigeminal nerve pain and glossopharyngeal nerve pain out of control through intravenous countermeasure. I would also consider and bring it up here because doctors are more willing and more happy to engage with intravenous steroids. So we're talking about methylprednisolone that is being applied to a patient's as an intravenous at a dose of between 500 milligram up to a gram per infusion. And then once that is started and is successful, and it is quite a helpful medicine in the emergency setting, then there is a mandate that the first infusion will have to be followed by a second and third infusion that is done on day 2 or day 3, or can do a Monday, Wednesday, Friday regimen of intravenous with 1 day break. But once you start it, you should apply a pulse of steroid IV and not just leave it at one dose of 500 or 750 milligram. And so those are emergency room options for
that's a lot
out of control.
We're going to run out of time. We want to have questions from outside, but
yeah, we can take some questions.
I want to ask about using opioids, and I want to have you comment on what's on the horizon. Is there anything on the horizon that's new and exciting that people should hold their breaths that might be helpful?
Yeah,
but first, what about opioids? Can opioids ever be used?
Opioids can also be used because practically there are just patients who are using opioids for whom opioid is a component of their treatment regimen, and for whom opioids are just the difference between some level of successful management and some level of derailed and non-functional management. If you enforce a strict non-opioid policy, there will be patients with trigeminal nerve pain who fall through the cracks. Of course, my directive and my principle has been to try to avoid opioids. I have gotten many patients off of opioids and replace them with more specific and non-opioid therapies. But I do know, I'm aware that there are patients for whom a controlled opioid prescription regime is a difference between a form of life that is acceptable versus a form of life that is not acceptable. And that we are away.
we're going to need 2 more hours for this. But no, before Allison comes in with the other questions, let me give you the chance. What's out there? Is there anything on your dream team for the future that might be available that's being studied?
Absolutely. Yeah, I think there will be incremental progress where we do clinical study and combine things. And I did not go into it. Low-dose naltrexone is also bolded on my slide here. It's a very important and very powerful medicine where I have helped a lot of people using low-dose naltrexone, not as a primary medication, but as an addition, like a second, third, or fourth medication. And we add low-dose naltrexone, and then the patient relaxes and everything becomes just much more relaxed. And this is a medication that I have also taken from treatment of fibromyalgia, where it was observed that it does help the fibromyalgia sufferer. And it's an opioid blocker that is given at very low dose, and it looks like it's helping the endogenous opioid system to also kick in. And it's also a treatment that affects a type of cell in the brain that is very likely a bad actor in this form of chronic pain, namely the so-called glial cell. And that low-dose naltrexone has a potency to calm down and to make less sensitive these glial cells, which without that, they would normally enhance the pain and enhance the damage and the inflammation that we have inside the brain of patients with chronic pain. So LDN, low-dose naltrexone, is good in chronic trigeminal nerve pain. I made that experience, and we will see clinical studies if they are done that would support that. And that I would call that incremental progress. And then there will be non-incremental progress that comes from, leveraging science of the 21st century toward trigeminal pain, and that can be things like what we try to do at Regeneron, rational discovery of target molecules and how we shut them down. But that can also come from companies who will use material science approaches, who will use neuromodulation, neurostimulation, and who will bring specific instruments to the form of treatment of pain that we haven't yet brought, and that in 2021 and beyond we are able to engineer, to construct, and to implement. So that's my prediction for what will happen with trigeminal pain in terms of progress, incremental progress, and also there will be non-incremental steps forward.
I think we need 3 more hours, but let's Allison come in with a couple of questions from a very large audience, I think, that's still out there. But I'm afraid we went so fast. Here we go.
Well, and I want to start there. Thank you so much, Dr. Liedtke. There was so much great information. We have a ton of questions. So first, I would like to ask you if you would help me follow up with some of these. Maybe we can, I can send them to you, and you can give the answers, and we can post those on our new website for people to come back and read, because there's just so many. We're just not going to get to all of them.
Okay, yeah. Principally happy to reply. Of course, cannot do medical sessions through the internet and just answer in a general manner, but I think the audience understands.
Absolutely. And a lot of requests.
Dr. Liedtke is now in the research field. He's not seeing patients. He can advise us, but he's not going to be able to do individual therapy, sadly, but excitedly, because he's going to do something for large groups of us in the next coming years.
Well, that's good to know in some ways, but people did ask how they can get in touch with you, how they could find you, how they can make an appointment. So that makes that answer clear. But there are also
appointment is no longer possible for treating individual patients through my position at Regeneron is not such that I have like Fridays. On Fridays I see patients at NYU or so. No, it does not happen. Yeah.
But they are interested in learning more about your research, so perhaps you would write an article for us talking more about your research and what you've found and what you're working on.
For the outlook, to like a perspective to say, okay, this is trigeminal nerve pain. This is happening in the field of trigeminal nerve pain research from my perspective, and trying to explain that at a level that is not for the science aficionado, but at a general level understandability.
Perfect. We'll nail you down.
Okay. So let me get to some of these questions. One question we got multiple times was asking what you think about THC and or CBD, either as topicals or.
Yeah,
you know.
Absolutely. Look, I listed here Marinol, THC in bold, and CBD products I list. So I have not seen in my 17 years of practice a patient who got significantly better just with that treatment by itself. I have not seen that, and therefore, for example, I also like to say, if cannabis were the answer to trigeminal nerve pain, we would know it. We would know it, because with this form of pain, and even if all the doctors in the world were fighting it, people would do it. And if cannabis, high-powered, high-percentage cannabis would wipe out trigeminal pain, we would know that. And I did speak with patients who tried it, and I have never heard it. So from that, I would still bold THC, because I have added Marinol as a script, is a prescription medicine. There's nothing illegal about it. It is a control level 4, if I'm not mistaken. I have prescribed that to many patients, and a proportion of the many patients I have prescribed it to have liked it. And that was a setting of a multi-drug pharmacy, where they had 2 or 3 medicines they were taking, and then we add Marinol, and then we play around with a dose, lower dose, higher dose, take more in the evening, spread it out over the day, and that has done a lot of good. So, and that there are patients that have, like, they have 3 tablets and then they get Marinol, and the difference is that with Marinol they can have a much more normal life, socially, professionally, and that's the difference. And without Marinol, it's sort of not that okay. And with Marinol, with THC, it is okay. So I do have that experience. I can report it. But Marinol alone, I have never seen somebody getting better, significantly better on Marinol THC alone. Then CBD products and cannabis. With that, I'd say I find that the safety profile of this is so benign that my take is try it out. And see what you get if you add that to the treatment regimen. And what do you get? Maybe you get improved sleep. Okay, great, get it, because improved sleep is so important. Or it will make the entire treatment better, like Marinol. That's also possible. And as the CBD products are mostly supplied as so-called oils, CBD oils, those I say apply to the inside of the mouth as recommended, and get the oil as close to the pain as possible, where if there is pain inside the mouth on the, let's say, mandible or maxilla or tongue, then the CBD oil inside the mouth is really good, because you get the plant-based compounds to the site where it hurts, where the nerve is irritated. And likewise, I say use it from the outside. If there is a site on the surface of the face, a cheek, or underneath the lip, or the wings of the nose, the forehead, try using the CBD on the outside. But that is like, I think after a certain period of time, a week or 2, there should be some feeling, okay, something is happening here for the good. And if not, then it was sometimes a little bit costly adventure in buying these CBD products, where that's one take or one recommendation I make for nerve pain. Don't use the low concentration versions. For nerve pain, do use the high concentration versions, and they are not cheap. So that's CBD products, but then overall, high concentration and not cheap is still very benign safety profile. And bottom line, let's just give it a try.
Great. I have 2 more that I really want to get in here. We had a bunch of questions about gabapentin and carbamazepine, and people wondering about them losing effectiveness over time, and also concerned about long-term side effects of some of these medications.
Okay. losing effectiveness with these drugs is possible, and it needs to be. That's where good pain clinics come in and have regular visits and talk that over with a pain doctor, with a pain provider, and see what can possibly be done. A mild dose escalation, that's fine. And sometimes I had patients where it's very clear that they need a bit more of the medicine during the colder months, and then during the warmer month they need less, and that's good. Then you vary the dosing, and that can prevent this form of the drug losing effectiveness, because you day in day out it's the same. So if you have a little bit, there is some variation that can prevent this. And I like to give this example. If a patient needs clonazepam to have a really good outcome and pain control, that for sure you cannot take clonazepam every day. And doctors would say, well, that's a benzodiazepine, you can't take that. Well, I have had patients who have taken clonazepam over years, and we pursued that they are taking it 5 days a week, and then the weekend they do not. And on the weekend they have an alternative approach that will bridge them over, and then they are on a 5-2 regimen, and like that they have their brain and their system not exposed to the medicine for 2 days, and that's like giving them a chance to reboot. And you can keep them on a medicine that otherwise could never be taken for extended period of times. You can keep them on it for years and years. And so then other long-term effects of these medicines, they're relatively safe, but then monitoring in the clinical setting where they are prescription medicines and not over the counter is that will have to be done. I'd say avoid other things that could increase toxicity, and we're talking mainly about liver, kidney, and that is, remain well hydrated, have the blood drawn for the liver kidney function. Don't do other things that can damage liver kidney, like taking too much ibuprofen, taking too much Tylenol, drinking too much alcohol, smoking. These type of things, the lifestyle issues have to be adjusted so that we avoid these longer-term toxicities. Patients have taken these medicines, carbamazepine and gabapentin, for years and years as treatments used for treatment of seizure disorders, or for things like bipolar disease, where the treatment needs to be distributed for years and years. Otherwise, the patient is really in an extremely bad state. And with that, those medicines can be given for long periods of time. And for example, in comparison with like over-the-counter ibuprofen or some of this Tylenol for that enhances your sleep, that for example is much more dangerous than being on a regular supply of carbamazepine or gabapentin under the supervision.
Dr. Liedtke, I have to get in my one question as a surgeon.
Go.
At what point do you say enough, you need surgery?
Yeah, that is when we're not running against the wall, and if it's a benign treatment and I have them on a drug regimen, they get their refills and it's moving forward smoothly. But if I have then the patient then develops a low sodium after carbamazepine, and that gets into real trouble, and I try another drug and they develop a nasty allergy, and in the meantime their blood pressure goes up, and that is hard to control because it's just difficult to do that. And at that point it's like, okay, we need to consider other options. And we found that your MRI showed that your artery was directly sitting on your nerve. You are a candidate for the microvascular procedure, so let's not withhold that from the patient. And my view is that this type of surgery should be an option for many patients. And for example, if the anesthesia would be difficult, then we are in 2021. Difficult to manage anesthesia can be managed by people who have more complex tools at hand. You can operate on patients who are of a certain age, who are in relatively good state for their age. That should be open. You can operate on a patient who has trigeminal nerve pain in the context of multiple sclerosis. It's not to say, oh, you have MS and therefore you are the operation, is out of the loop for you. Looking at it carefully, there are MS patients for whom the microvascular procedure is a very, very good option. And so in that respect, I'd say that is an important decision to be taken, but is also one needs an open mind and make a good call. Like, my attitude toward that is also kicking the can down the road. That is something perhaps not, or perhaps to avoid, because if something has to be done one day anyway, and you know that, then why not do that earlier? Or what is the argument to delay?
So again, to wrap things up, if I can, medical treatment, until medical treatment can't be done anymore, there is surgery. We do have a role as surgeons.
Absolutely.
Just to get that in.
Absolutely. Well, I mean, if, for example, I had a patient who was flying airplanes, and then it was about, you cannot even give her these medications appearing on her list. Is like, okay, you're taking these medications, there you go, you cannot fly anymore. So if she could be cured through or made symptom free through a microvascular procedure, that comes in, and that has to be taken into account. So what is the situation of the patient is also an important decision factor when reaching this decision. And absolutely, for that reason, that trigeminal pain doctor as a non-surgical doctor is so important to be in close touch with the colleagues who can do operations skillfully. And that is something that over the years I think I have managed to do that with colleagues at Duke, and also a few of my patients have gone to U, and there are doctors at Hopkins and in University of Pennsylvania with whom I have collaborated. So I think that's really important to have a very good communication, and that the referrals between the medical treatment doctor and the surgical treatment doctor are smooth, and that one has good understanding. So there's a mandate on the doctors to have good open channels of communication on, and for the reason of not professional enjoyment, but on behalf of the patient.
Allison, I think we need to give Dr. Liedtke a deep breath, and he's got.
I need to give him a break. But what I would like to I just want to let everyone know, thank you so much for submitting your questions. You did not do it in vain, because I will get the questions answered, and we will let you know whether those will be posted on the website or whether we will send those out to you, because there were so many important questions. And
okay, do 3 more, and then we'll conclude.
I'm gonna give you one more, because I thought this was a really great question.
Okay.
How does a patient work with his or her doctor, if the doctor seems to be resistant, in helping the patient try different combinations or different ratios of medication? How does the patient sort of be empowered to force those changes?
I think these days you would. My suggestion is to bring that up during the visit, and if the doctor has a certain philosophy that they say only like this, and it's just sort of making the choices more narrow, then I think what comes to my mind is to be, honest, straightforward, polite, and diplomatic in the communication, and see that whether perhaps another doctor could be a better outcome to work with somebody else. And I sort of looking back, I have had some patients that went with other doctors and said, okay, this looks like it's working better for me. And I say, my comment was, I'm happy for you. How can I help? And that, understandably, that there are people who have different personality or is something, and that there is somebody out there who is just matching with that better. Where, trigeminal pain, all of medicine has that as a feature, but I think trigeminal pain in particular is that what the patient is suffering from and what the doctor brings to the table. There has to be some form of wavelength, alignment of the wavelength, and if there is not, then it's, you know, in the end, if the patient gets better, that's it. and we cannot have that, you know, the job satisfaction of the doctor. That's not the number one thing we have to count at the end of the day. But you know, pain control and improved lives, that's what really counts, and that's the major guiding principle here.
I think that's a great analogy. You have to be on the same wavelength.
Or at least compatible, you know. Yeah. And that is, I mean, looking back, it's a human. And there could be people whose wavelength is just that it just doesn't wavelength with me. And then I can give some professional advice, but for this longer term relationship with, you know, carefully calibrating and getting to know the patient and what is going on in their lives and in their families, etc. And I'm just not the right guy for that. And I could be, yeah.
Allison, wrap it up.
Yeah, I think that's wonderful. And again, you know, if you'll answer some questions in a general way that we can share with the community that would help a lot of people, that would be wonderful. And thank you everyone for showing up. We're going to continue to have topics like these. Obviously, this was a very popular topic and we got through a lot, but I understand that there's so much more we'll have a chance to get to.
Okay, so we come through. Let me show you the one slide we should definitely show here before we go. Okay, so see that? Trigeminal pain evokes post-traumatic stress disorder and discrimination in people. That's something that has come to me, and it definitely needs to be put up here. And the regulatory jungle needs to be cleared so that we can deal with this disease better. And then we should do something like the MD Anderson Cancer Center is doing with cancer. If you go to Houston Airport, you see cancer with a red strike through, we got your number. And that is what we should be doing with facial pain. We got your number because we can. So that's definitely, I'm not making this up or putting here some fancy smiley face up. That's what we should do. All right.
Thank you very much.
Thank you everyone for attending. Dr. Liedtke, thank you so much. That was amazing. And Dr. Brown, thank you so much. And everyone, have a good night.
Thank you.
Thank you.
Thank you, Allison.
Everyone,
Thank you, Dr.
Great.